Hello everyone and welcome to my channel. Today we will study the psychiatry. We have started the medicine preparation, the CVS, pulmonology, endocrinology, rheumatology and CNS units are already covered. Now we will discuss the psychiatry. So the following topics are the most important topics of psychiatry, and you should learn the psychiatry topics, especially for the counseling stations in the prof exam. These topics are schizophrenia, major depressive disorders, panic anxiety disorders, phobic anxiety disorders, anorexia nervosa, convergent disorders, and postpartum depression. Okay, now coming towards our first topic, that is schizophrenia. We are having a scenario that there is a 35-year-old man asking for removal of a software implanted in his body by his neighbor. He told that his wife is hiring this neighbor to spy on him for last 6 months. He has been hiring them, taking about and all details of his life. His physical and systemic examination is unremarkable. So what is the diagnosis and the management? The differential diagnosis of schizophrenia are depression, mental retardation, mania, mental retardation, delusions, brief psychotic disorders. The definition of schizophrenia is that it is a thought disorder characterized by delusion, hallucinations, and lack of insight, neurodevelopmental disorder, brain developmental abnormalities, genetic predisposition, environmental influence, and triggers. Positive symptoms, negative symptoms, cognitive impairment, and mood and anxiety symptoms are present. The risk factors are strong genetic predisposition, obstructive complication at the time of birth, urban upbringing, decreased brain size, greater rodentum of temporal lobe volume. Now, the investigation or diagnostic options are acute schizophrenia and chronic schizophrenia. For acute schizophrenia, the investigations options are first rank symptoms of the acute schizophrenia, that is from mnemonic A, B, C, and D. For A is auditory hallucination, that is second and third person hallucination. Then for B is broadcasting of the thoughts, which is thought insertion, thought withdrawal, and thought broadcasting. The third number is control feelings, which is impulse or act, and the fourth is delusion. Okay, the chronic schizophrenia investigations are evolution, that is apathy and loss of drive, then autism, that is social isolation and withdrawal, then alogia, that is poverty of speech, then blunted, that is flattened affect, and then catatonia, that is adopting awkward postures for prolonged periods, and that poor self-care. Okay, so for the schizophrenia, following investigations or clinical behaviors are checked. Then the management options for schizophrenia are: first episode of acute attack requires hospital admission, then subsequent acute relapses and chronic schizophrenia are treated as an outpatient basis. The treatment options are antipsychotic medications. These agents are dopamine receptors antagonists, and the types are first generation and second generation. In first generation, we have chlorpromazine and haloperidol. In the second generation, we have olanzapine and clozapine and risperidone. These agents are taken about 2 to 4 weeks to act. So we have discussed the topic schizophrenia, the scenario and the diagnostic points. Then what are the differential diagnosis, the definition, the risk factors, who are at more risk of schizophrenia. Then we discuss the investigation options for both acute schizophrenia and chronic schizophrenia. Then we discuss the management option, then the treatment option, then the types, that is first generation and second generation. Now coming towards the next topic, that is major depressive disorders. We are having a scenario that there is a 40-year-old man complains of low mood and fatigue, has loss of libido, wakes up at 2 a.m. and unable to return to sleep. He feels guilty about death of his mother 2 years ago. Another scenario is that there is a 30-year man having low mood and fatigue, poor appetite and loss of libido, disturbed sleep, wakes up at around 2 a.m. and remains awake after that. Lost job from 3 months, trying for new job, unable to get it. Guilt of not supporting his family is there. Now the definition of the major depressive disorder is that it is a mood disorder. The risks are genetic predisposition, chronic illness, and stressful life events. Female ratio is greater than male. Hypofunction of the monoamine neurotransmitter serotonin and norepinephrine is present. The investigation options of major depressive disorders are diagnostic, that is depressive mood. For 5 signs and symptoms are present for at least 2 weeks. Then the SIGECAPS mnemonic is remembered for the investigation and diagnosis. S is for sleep, which is increased during day and decreased during night. I is for interest, which is loss of interest in pleasurable activities. Then G, there is guilt of feeling of worthlessness. Then there is energy, there is lack of energy. Then concentration, that is loss of concentration. Then appetite, increase or decrease. Then psychomotor, that is agitation, anxiety or retardation, and lethargy. And for S is suicidal ideas. The management options for Major depressive disorders are that there are three basic types of the treatment for depression. That is medication, psychotherapy, and electroconvulsive therapy. May be used singly or in combination. The pharmacological treatment are antidepressant, that is tricyclic antidepressants are used, amitriptyline and imipramine. Then selective serotonin reuptake inhibitors are used, which are sertraline, fluoxetine, citalopram, and escitalopram. Then monoamine oxidase inhibitors are used, which are phenelzine and uh, transylcyclopramine. Then atypical antidepressants are used, which are bupropion, mirtazapine, valenzapiine, and trazodone. The psychotherapy is it includes cognitive behavioral therapy, then helps to change the negative thinking. Then interpersonal therapy, which is improving troubled personal relationship and adapting to the new life cycle. Then electroconvulsive therapy is done if symptoms get severe and not improving with above therapies. The electroconvulsive therapy is given. Okay, so we have discussed the topic major depressive disorder, then the scenario for it, then what is the definition and what are the risk factors, investigations that are done, then the diagnostic points, which is sleep, interest, guilt, energy, concentration, appetite, psychomotor activity, and suicide. Then the management is done. The pharmacological treatment is antidepressants, selective serotonin reuptake inhibitors, monoamine oxidase inhibitors, atypical antidepressants are given. Then psychotherapy is done and electroconvulsive therapy is done. The next topic that we are having is panic anxiety disorders. We are having a scenario that there is 20 years old female brought to hospital by her parents with history of anorexia, loss of interest in life with two failed suicidal attempts in past. On examination, she is hyperventilating and is having carpal pedal spasm. She is afebrile, BP is 110 by 75, has no neck rigidity and unremarkable systemic examination. Then another scenario is that there is a young female who was brought to emergency by her parents with 3 days history of anorexia and mutism. Since morning, she has developed carpal spasm. In past, she had an unsuccessful suicidal attempt. On examination, she has deep signing inspiration, BP 120 by 80, pulse is 110 per minute and regular. She is afebrile, no neck rigidity is present. Rest of the systemic examination is unremarkable. So, what is the diagnosis? What are the immediate measures that you will advise to relieve carpal pedal spasm? Then the treatment options and the counseling and the expectations on arterial blood gases. The definition of the panic anxiety disorder is that it is a recurrent panic attack episodes of extreme anxiety, often with marked physical symptoms. The clinical features or symptoms are tachycardia, hyperventilation, sweating, dizziness, chest pain, fear of dying, and agoraphobia. The investigations that are done for the panic anxiety disorder are ABGs. It will show alkaline pH above 7.6, low CO2 due to washout, and HCO3 may below as a compensation to alkalosis. Then immediate measures are done to relieve the carpopedal spasm, that is ask attendant to bring a paper bag and then ask patient to rebreathe in bag. Gradually CO2 increase in blood and tetanus disappear and patient feels better. Consider intravenous diazepam if above measures fail. The management options for long-term management is antidepressant drugs, that is serotonin reuptake inhibitors, and tricyclic antidepressants should not be considered in this case. It causes suicidal tendency. Non-pharmacological treatment is interpersonal therapy, cognitive behavior therapy, and electroconvulsive therapy. Then the counseling of the patient is done, which is the detailed history is taken, ask about condition which she got most annoying for her and other issues like sexual abuse, loving issues, financial, etc. Reassure and fully listen to her problems, encourage her to talk, don't dismiss her feelings, sleep pattern and its correction, increase her confidence level, change is negative, think to positive thinking, and ensure family support. So we have discussed the topic panic anxiety disorder, we have discussed the scenario, then we have discussed the definition, the clinical features and symptoms, then investigation options which are ABGs, and immediate measures to relieve carpopedal spasm, then the management options, then the non-pharmacological treatments, and then the counseling. Now coming towards the next topic, that is phobic anxiety disorder. We are having a scenario that there is a 42 years old college teacher complains of palpitations and excessive sweating symptoms worst in gathering or when she is delivering a lecture with doors closed. She feels immediately better in open space. On examination, pulse is 100 per minute, regular, BP is 130 by 85, hands are cold with fine tremors, and systemic examination including thyroid is unremarkable. Investigations X-ray shows X-ray, chest, ECG, and thyroid function tests are normal. So the definition of the phobic anxiety disorder is that it is an excessive and abnormal focus and avoid specific objects or situations. Okay, it is of two types, the social phobic anxiety disorder and specific. In social, fear of the humiliation and embarrassment in social situations, and in specific phobia, fear and avoidance of an object or situation, fear of height, fear of animals. The management options for phobic anxiety disorders are pharmacological, that is antidepressants, drug of choice, benzodiazepines, and beta blockers for performance anxiety, and stage fright. The non-pharmacological methods are patient's education, lifestyle changes, psychotherapy, cognitive behavior therapy, and graded exposure of the fecal objects or situations. Explanation and reassurance are essential, especially when patients fear they have serious medical condition. Positive thinking, regular exercise, good enough sleep, and healthy nutrition contributing factors to the treatment. So the phobic anxiety disorder, we have discussed its scenario and the definition. Then there is social and specific phobia. Then the management options are both pharmacological and non-pharmacological. Coming towards anorexia nervosa, we are having a scenario that there is a 17-year-old uh, patient brought to the hospital by her mother, who says that she has been losing weight for last 3 months and is amenorrheic. Upon questions from girl, she insisted that she is overweight and needs to diet even more. Another scenario is that 20 years old studying college student brought by mother to hospital saying that she has lost weight over last 4 months and has got an amenorrhea. Got good academic record on examination. Girl is thin and frail, but she still believes that she is overweight and needs to diet. So the diagnosis, the hormonal imbalance, and the cause of amenorrhea, the counseling and the treatment. The definition of anorexia nervosa is that it is a eating disorder characterized by failure to maintain normal body weight, fear and precaution with gaining weight, and unrealized self-evaluation is overweight. The age is 15 to 19 years. The diagnostic criteria is weight loss of 15% of total body weight or BMI less than 17.5 mg per kg, avoidance of high caloric food, amenorrhea for at least 3 months, distortion of body image, so patients regard themselves as fat even when severely underweight. Hormonal imbalance between estrogen and progesterone had caused her to be amenorrheic. The treatment options for anorexia nervosa are hospitalization and the correction of metabolic disturbances. Behavioral therapy, family behavior therapy has efficacy among adolescent but not adult patients, and antidepressants are used. These are tricyclic antidepressant, that is amitriptyline, and SSRI, that is escitalopram. Okay. So we have discussed the anorexia nervosa, the scenario for anorexia nervosa. Then we discussed the definition of this anorexia nervosa, the diagnostic criteria for it, and the treatment options, which are hospitalization, behavioral therapy, family behavior, and antidepressants. Now another topic is convergent disorder. We are having a scenario that is a 45-year-old lady sudden onset of loss of vision of both eyes was referred to psychiatry OPD by ophthalmologist after excluding ophthalmological and neurological causes for her blindness. In past, she had similar episodes of loss of vision in her right eye after knowing about second marriage of her husband. All these episodes respond to psychiatric therapy. She is withdrawn and has disturbed sleep and weeps most of the time. Her baseline lab investigations were normal. So the diagnosis, investigation, management, and counseling. The definition of the convergent disorder is that in this disorder, individual has sensory or motor symptoms that suggest a general medical conditions. However, symptoms are related to stress or conflict. The investigations to exclude brain pathology, ECG scan, brain MRI, brain CSF examination, and MR angiography. The management options are rule out general medical conditions that may be responsible for symptoms, then psychotherapy to establish caring relationship, then cognitive behavior therapy, briefly monthly visit with the parental physical examination, and physical therapy. Then the drugs that are used are antidepressants, that is citalopram, and SSRIs, and anxiolytics, that is alprazolam. The counseling for the convergent disorder is that greet, introduce the patient and reassure the patient, then exclude disease but avoid unnecessary investigations, demonstrate patient that you believe their complaints, establish collaborative relationship, then give positive explanation of the symptoms, reassure and ask for most worried things and how to avoid them, then offer with appropriate psychotherapy, and antidepressants and anxiolytics are given. Okay, so we have discussed the topic convergent disorders, the scenario for it, then the definition, the investigation, and the management options, and the drugs that are used for it, and then the counseling. Now, coming towards the postpartum depression. We are having a scenario that there is a 27 years old female 4 weeks postnatal has been brought by her husband complaining that since birth of their child, patient has become increasingly irritable. Her appetite has reduced and is having to intense. At the times trying to harm baby. Her appetite has reduced and is having no interest in her baby, at times trying to harm baby. Last week she tried suicidal attempts but was failed. So what is the diagnosis, the counseling, and the treatment, the pharmacological and the non-pharmacological treatment? Postpartum depression is disturbed sleep, appetite, social withdrawal, and weakness are suggestive of depression disorder, clinically dangerous based on history. So the Clinical diagnosis is based on the history. So the management is pharmacological, which is hospitalization, and drugs are given, that is antipsychotic drugs, chlorpromazine and clozapine. Then antidepressants are given, which are SSRIs and tricyclic antidepressants. Then electroconvulsive therapy is provided in severe cases. The non-pharmacological drugs are psychological support by family, interpersonal psychotherapy, adaptive to new life, and cognitive behavioral therapy, which help to change the negative thinking, and breastfeeding should continue. The counseling of the patient is done. Take complete history about the duration of marriage and her relationship with husband and his in-laws, and the entire history of antenatal time period. Then discuss disorders with her and family members. Ask family members to support her psychologically. Then give positive explanation regarding her symptoms. Ask her to slow and steady get adapted to new lifestyle and get adapted with motherhood. Then offer sessions of CBT and give mild to moderate doses of antidepressants along with psychotherapy. So here we have discussed the last topic, that is postpartum depression. We have discussed the scenario, then what is postpartum depression, the definition, then we discussed the management, which is both pharmacological and non-pharmacological. And pharmacological hospitalization is done, and the antipsychotic, antidepressant and electroconvulsive therapy is given. The antipsychotic drugs are chlorpromazine and clozapine. The antidepressants are SSRIs and tricyclic antidepressant. SSRIs are then the non-pharmacological treatment is psychological support by family and interpersonal psychotherapy, and then the counseling of the patient is done. So we have discussed the psychiatry, the unit, all important topics, that is schizophrenia, then major depressive disorders and panic anxiety disorder, phobic anxiety disorders, anorexia nervosa, conversion disorder, and postpartum depression. In the next section, we will start the medicine A section, B section. Here we have covered our medicine A section. Thanks for watching.